all right for me to start, I'll just go ahead. So the title of this talk today is the use of biologics for severe asthma. My name is Rana Misiak. I'm a senior staff allergist here at Henry Ford. I have no conflicts of interest related to what I'm talking about today. So the aim today is to define severe asthma and discuss which endotype of asthma may have a favorable response to the currently approved biologics. And we'll discuss the mechanism of action, indication, and efficacy of 5 FDA-approved biologics. So asthma, as you all know, affects about 300 million people worldwide, and about 8 to 10% of the US population has asthma. And severe asthma occurs in about 3 to 10% of those asthmatics and is associated with a lower quality of life and a higher morbidity and mortality. The definition of severe asthma that I will use for the talk today is asthma that requires a high dose of an inhaled corticosteroid plus a second maintenance medication or the use of systemic steroids to maintain control, or asthma that remains uncontrolled despite the above medications as measured by exacerbations, poor symptom control, or impaired lung function. This was the original EPR3 from 2007. So the types of patients that we're thinking about for biologics are really step 5, step 6. Some of the biologics have an indication even for step 4 asthmatics. So you can see here that they mentioned considering OMALIZUMAB for these step 5, step 6 patients. So our more recent update from a couple months ago, you can see that additional biologics are mentioned here, which had since been approved since 2007. So anti-IgE, anti-IL-5, anti-IL-5 receptor, and anti-IL-4 and IL-13, which are the ones we're going to talk about today, again, for step 5, step 6 here. So when control is not achieved with a high dose ICS, generally with the addition of a long-acting beta agonist, and adherence and inhaler technique have been addressed, that's when we consider the addition of a biologic. It's important to note that problems with adherence and inhaler technique account for about 50 to 80% of uncontrolled asthma. Other things to think about prior to a biologic would be considering a long-acting muscarinic antagonist or a LAMA. These have been shown to increase lung function as well as time to first exacerbation, and also to consider maximally treating any coexisting diseases that the patient has, including reflux, chronic rhinosinusitis, severe allergic rhinitis, vocal fold motion abnormalities, or obstructive sleep apnea. This is just kind of a flow through of the thought process that one would go through. So first, confirming the asthma diagnosis, looking at symptom history, their lung function, if they have hyperresponsiveness, and then assessing whether they've received an adequate trial of a high dose ICS plus LABA. Looking again at their inhaler technique and adherence. If those measures have not been optimized yet, then making sure they know how to use their inhalers, checking for adherence. And then really for both these categories, once you've optimized that, then taking a look at those coexisting conditions that we talked about, making sure people have a written asthma action plan that they understand and they can follow. And then the non-biologic add-ons that we talked about, such as tiotropium, macrolides, leukotriene modifiers, oral steroids, theophylline, but of course thinking about the risks and benefits of some of these additional therapies. Whichever of these therapies that's attempted, if it doesn't work, then discontinuing it, thinking about something else. If they have a good response to one of these other therapies, then obviously pursuing that. If one of the non-biologic add-on therapies does not result in the response that you're looking for, and again, thinking about adherence, side effects, and such, then you would think about a biologic and assess their inflammatory phenotype. So some of the goals with the addition of a biologic are to reduce exacerbations, decrease need for systemic steroids, reduce asthma symptoms, improve quality of life, and improve lung function. A biologic is an antibody, a vaccine, or an interleukin used to treat disease. And the therapy alters the immunopathogenesis of asthma instead of treating the downstream effects of airway inflammation and bronchospasm. So the currently approved biologics that we have are most effective for the T2 high endotype. Different asthma endotypes can be defined based on the degree of Th2 inflammation, which in turn are defined by the level of expression of Th2 cytokines. So in T2 high inflammation, there are elevated levels of interleukin 4, interleukin 5, and interleukin 13, which are secreted by CD4 type 2 lymphocytes or Th2 cells. Cross-sectional studies suggest that about 50% of patients with asthma have T2 high disease. T2 low disease is a little bit more difficult to characterize and define. These are some of the features comparing T2 high and T2 low. So you can see the age of onset is generally earlier for T2 high as compared to T2 low. Symptoms may be significant in both. Life-threatening exacerbations can be more frequent in T2 high as compared to T2 low. Obesity and metabolic dysfunction can be often present with T2 low and plus minus in T2 high. Lung function there can be demonstrated more obstruction sometimes with T2 high as compared to T2 low, with more responsiveness to bronchodilators in T2 high as compared to T2 low. Allergic sensitization is generally present in T2 high and can be absent in T2 low. Exhaled nitric oxide, kind of variable with both, but can be normal to elevated in T2 high and low to normal in T2 low. Airway eosinophilia generally is present in T2 high and absent in T2 low. And airway neutrophilia can be present in either. And it's thought that the T2 high asthma may be more responsive to corticosteroids, and T2 low has more of that steroid resistant picture. Sorry, I need to move this over a little bit so I can see. Okay, so looking at the effects of interleukin 4 and interleukin 13, they have many similar effects. Effects include epithelial thickening, goblet cell hyperplasia, mucus overproduction, subepithelial fibrosis, smooth muscle hypertrophy, B cell isotype switching with increased IgE production, recruitment of eosinophils, differentiation of T cells into Th2 cells, and IL-13 also stimulates bronchial epithelial cells to produce periostin. Another very important cytokine in T2 high inflammation is IL-5. IL-5 mediates the recruitment, migration, activation, and maturation of eosinophils, leading to induced airway inflammation. With T2 high inflammation, there can be elevated blood and sputum eosinophils. Eosinophils in the airway release pro-inflammatory cytokines and other mediators that result in mucus production, smooth muscle contraction, angiogenesis, and remodeling. There can be elevated FeNO or fractional exhaled nitric oxide and generally elevated serum IgE. So just a word on FeNO. It's thought to be a biomarker of eosinophilic inflammation in the airway. It may predict responsiveness to inhaled corticosteroids. Levels can correlate with the presence of asthma, but the exact role of FeNO in the diagnosis and characterization of asthma is really not completely defined. So in T2 low asthma, the airway inflammation can be either neutrophilic or it could be paucigranulocytic, where you really have neither eosinophils nor neutrophils. Generally, we do see the normal eosinophil levels in the sputum and in the airway. So here we can see that with T2 high asthma, the endotype that we see, the cytokines that we talked about, IL-4, IL-5, IL-13, TSLP, involvement of mast cells, Th2 cells, ILC2 cells, all contributing to this phenotype of the eosinophilic inflammation. Whereas in T2 low asthma, the endotype we think about can be neutrophilic, Th1 cells, Th17 cells. The cytokines we think about include interferon gamma, TNF alpha, IL-17, and that can contribute to that phenotype of either that neutrophilic inflammation or that paucigranulocytic inflammation. Sorry, I need to move this bar up here. I don't know how to move that bar up there, but you can, I think you can see at the top of the slide, but basically just looking at the inflammatory mechanisms that lead down to the, basically the signs and symptoms that we see with asthma. So whether the initial trigger was an antigen or an irritant or a virus, leading to that inflammatory cascade, resulting in hyperresponsiveness, remodeling, mucus production, smooth muscle constriction, and hypertrophy. And then these changes in the airways contributing to the exacerbations, the symptoms, and the airway narrowing that we see. So now we kind of get into the specific targets for these biologics that we'll spend the rest of the time talking about. So really just starting up in here, again, we think about the initial trigger, whether it's an allergen, a virus, or a pollutant as being the initial trigger. So after this initial stimulus, then alarmins get generated, including IL-25, IL-33, TSLP, and then basically this Th2 inflammatory process commences. So the interaction between with the dendritic cells leads to the Th2 cells to be secreting IL-4, IL-5, IL-13. And these cytokines then have effects on the airway epithelium, on the smooth muscle, on the eosinophils, and on the B cells. B cell isotype switching occurs with IgE production. When the allergen cross-linking occurs on a mast cell, there is subsequent mediator release from these mast cells, including histamines, leukotrienes, tryptases, and prostaglandins. And then also you have that innate lymphoid type 2 cell, or the ILC2 cell, which also secretes interleukin 4, 5, and 13. So here we have the 5 biologic agents that we'll be talking about today. So OMALIZUMAB, which is anti-IgE, so it acts here. MEPOLIZUMAB, which is anti-IL-5, and acts here. Breslizumab, also anti-IL-5, and acting on that same target. Benralizumab, which is anti-IL-5 receptor alpha, which acts here. And then DUPILUMAB, which is anti-IL-4 receptor alpha, which acts here as well as here. So just looking back at kind of the timeline of when these different medications were approved. So OMALIZUMAB has been around the longest. It was approved for moderate to severe allergic asthma back in 2003. And then more recently was approved for chronic refractory urticaria in 2014. The next to be approved were MEPOLIZUMAB and Breslizumab, which were both approved in 2015. Benralizumab followed in 2017. The FDA indication was for severe eosinophilic asthma. Since then, MEPOLIZUMAB has also been approved for EGPA in 2017. And then DUPILUMAB was initially approved for atopic dermatitis in 2017, and then was approved for asthma, for moderate to severe asthma with an eosinophilic phenotype or oral steroid dependence in 2018. And then the following year, it was also FDA approved for nasal polyps. So normally in a, so starting with OMALIZUMAB, which is anti-IgE therapy. So normally in a type 1 hypersensitivity reaction, allergen cross-linking occurs at the IgE that's bound to surface Fc-epsilon-R1 receptors on the mast cell. So this activates the mast cell or basophil, leading to mediator release of the cytokines, histamines, prostaglandins, and leukotrienes, which leads to allergic inflammation. When that allergen binds to IgE on Fc-epsilon-R1 on the antigen presenting cell, that also leads to antigen presentation and the immune response. So with OMALIZUMAB, these effects are blocked. So what OMALIZUMAB is a recombinant humanized IgG1 antibody. And you can see it binds here to that Fc region of free IgE, forming complexes which block IgE from binding to the high affinity IgE receptor, which is that Fc-epsilon-R1. It prevents the release of further inflammatory mediators and the downstream inflammatory cascade. This also results in downregulation of the Fc-epsilon-R1 on mast cells and basophils, which further blunts the allergic response. free IgE is reduced by about 96%, although the total IgE levels increase if you were to measure them. So as we discussed earlier, it was the first biologic that was approved for asthma in both the US and Europe. In 2003, when it was approved, it was for ages 12 and up. More recently, in 2016, it did receive an indication for age 6 to 11 years old as well. And the listed indication is moderate to severe persistent allergic asthma, having a positive specific IgE result to a perennial aeroallergen, and incomplete control with inhaled corticosteroid, as well as a total serum IgE between 30 to 700 for age 12 and up. And for that younger age group, that level can go up to 1300. So findings from the EXTRA and INNOVATE trials, these were patients that had difficult to control severe asthma. And they found that omalizumab did reduce the rate of asthma exacerbations by about 25% at 48 weeks as compared to placebo, as well as improved lung function by about 94 milliliters more than placebo at 28 weeks. Omalizumab improves health-related quality of life. Patients can often decrease their daily inhaled corticosteroid use, reduce their beta agonist use. There can be a trend towards a decreased total dose of oral steroid use. However, it did not improve the likelihood of completely discontinuing chronic oral corticosteroid use. Looking at different biomarkers that may predict response. So pre-treatment total IgE levels actually do not predict response to treatment. So benefit has also been seen in patients with total IgE levels both higher and lower than the current FDA-approved range. Some studies have shown that it's more efficacious in patients with higher levels of blood periostin, blood eosinophils, or FeNO values. And other studies have shown that eosinophils greater than 300 respond better with a 60% decrease in asthma exacerbations. The PROS study, this was one of the studies that came out of the ICAC study, which is the Inner City Asthma Consortium. Henry Ford in Detroit was one of the sites for this, with Dr. Zarate as the principal investigator. So PROS stands for the Preventative Omalizumab or Step-Up Therapy for Fall Exacerbations. This was a study in kids, but they found that pre-season treatment with omalizumab, so it was given September through November, and it reduced fall seasonal asthma exacerbations in inner city children who had exacerbation-prone asthma. So the rate of exacerbations when they were treated with omalizumab was 6.4% as compared to 36.3% in placebo. There was a second arm of the study where in addition to all the kids received guidelines-based asthma care, but in this group, they additionally received an ICS boost. So they had an additional dose of Flovent or fluticasone that they were taking daily. And you can see here that it's almost very similar. So the group treated with omalizumab, their exacerbation rate was 2% as compared to 27.8% for those who received that ICS boost. And it's thought that omalizumab likely has some type of antiviral effect via an interaction with interferon alpha. And I think that's still being kind of investigated as far as what that interaction is with that viral response. So moving on to the anti-IL-5 therapies, so looking at mepolizumab, restylizumab, and benralizumab. So mepolizumab and restylizumab, so they're both monoclonal antibodies that bind to IL-5, preventing it from binding to the IL-5 receptor alpha chain that's on eosinophils and basophils. This leads to decreased maturation, migration, and activation of eosinophils, leading to decreased blood and sputum eosinophils. It also leads to decreased expression of the IL-5 receptor on eosinophils and basophils. Benralizumab, shown here, this binds to the IL-5 receptor alpha chain on eosinophils and basophils. So it prevents IL-5 from binding to the receptor and also triggers cytotoxic killing of the eosinophils and basophils. So mepolizumab, FDA approved in 2015 for severe eosinophilic asthma ages 12 and older. And then in 2019 was also approved for a younger age group of 6 to 11 years old. There's no specific blood eosinophil threshold that's listed, but 300 cells per microliter is often used, or 150 cells per microliter if the patient is on oral steroids. Ruxolitinib, FDA approved in 2015 for severe eosinophilic asthma age 18 and older. Again, there was no specific blood eosinophil threshold, though generally 400 cells per microliter is used. And then benralizumab, FDA approved in 2017, severe eosinophilic asthma age 12 years and older. No specific blood eosinophil threshold is listed, but generally 300 cells per microliter is used. Okay, so in the MENSA trial, so this was mepolizumab as adjunctive therapy in patients with severe asthma. These were patients that had 2 or more exacerbations per year despite high dose ICS. And they found that mepolizumab demonstrated a reduction in asthma exacerbations about 53% and found improvement in lung function by about 98 milliliters. So mepolizumab reduces the rate of asthma exacerbations, improves asthma control, and improves quality of life. In the SIRIUS trial, this was the steroid reduction with mepolizumab study. These patients were steroid dependent. They had at least 6 months of oral steroid use before enrollment, had an absolute eosinophil count of 150 during the optimization phase or 300 at some point in the past year, and run high dose ICS plus another controller. And they showed that patients treated with mepolizumab were able to reduce their oral steroid dosage by 50%, and 14% were able to discontinue their OCS completely. So looking at if there are any biomarkers that predict response. So in the MENSA trial, the blood eosinophil count was 150 cells per microliter at screening, or 300 or more in the past year. Then when they looked at a sub-analysis of 177 patients who had a blood eosinophil count of greater than 500 cells per microliter, they found a reduction in exacerbation rate of 80% and an improvement in their FEV1 of 132 milliliters, suggesting that those with a higher blood eosinophil count may have even greater benefit. In this study, neither FeNO, total IgE, nor allergen sensitization predicted a response to mepolizumab. So moving on to ruxolitinib, in the BREATH program, they found a reduction in exacerbation rate of about 50 to 59% and an improvement of FEV1 of about 100 milliliters. With ruxolitinib, there was found to be reduced exacerbation frequency, reduced beta agonist used, improved lung function, and improved quality of life. A reduction in oral steroid use was not specifically examined as an endpoint. In the CALIMA study for benralizumab, CALIMA is the efficacy and safety of benralizumab in adults and adolescents inadequately controlled on ICS plus LABAs. Benralizumab reduced exacerbations by 28 to 36% at the every 8-week dosage, as well as improved lung function by about 116 milliliters at the every 8-week dosage. In the Sirocco study, which was looking at the efficacy and safety of benralizumab added to high-dose ICS plus LABA in patients with uncontrolled asthma study, they found a reduction in exacerbation rate of 51%. So benralizumab is been shown to improve symptom scores, improve lung function, weaning from oral steroid use, and reducing exacerbation frequently. In the ZONDA study, which was specifically looking at the oral steroid sparing effect of benralizumab, patients were able to reduce their oral steroid dose by 75%, and 52% were able to discontinue completely. These participants had an absolute eosinophil count of 150. They were on high-dose ICS plus LABA plus oral steroids in the preceding 6 months. Some of the predictors of efficacy include oral steroid use, nasal polyps, more than 3 exacerbations in the prior year, age 18 and older, and a higher eosinophil count. So overall, if you look at the 3 different IL-5 therapies, according to a Cochrane review from a couple of years ago, but they evaluated 13 randomized trials looking at mepolizumab, restylizumab, and benralizumab, and they found that all 3 treatments reduced rates of exacerbation by about half and improved quality of life. So moving on to DUPILUMAB, which is anti-IL-4 and anti-IL-13 therapy. So DUPILUMAB is a monoclonal antibody that binds the IL-4 receptor alpha chain that blocks both IL-4 and IL-13 receptors and their signaling through the STAT6 pathway. It also decreases IgE levels by about 40%. It was FDA approved in 2018 for severe asthma in patients 12 years and older with either an eosinophilic phenotype or corticosteroid-dependent asthma. In the QUEST study, the risk of asthma exacerbation was decreased by half, and a greater effect was seen in those with an absolute eosinophil count of at least 300, and also in an elevated FeNO of 25 parts per billion or greater. And in the QUEST study, participants were 12 years and older with at least 1 exacerbation in the past year, despite medium to high dose ICS and up to 2 additional controllers, could have been either LABAs or leukotriene receptor antagonists. In the QUEST trial, improvement in lung function of 200 milliliters was seen with DUPILUMAB, and this was in the group with elevated eosinophil counts of greater than 300 cells per microliter. In the VENTURE study, this was the evaluation of DUPILUMAB in patients with severe steroid-dependent asthma study. They found a decreased dose of oral steroids by 70% with DUPILUMAB and a decreased risk of exacerbation by 59%. A pre-specified eosinophil count was not required at study enrollment, and they found that benefit was seen even if the eosinophil count was less than 150 cells per microliter. So DUPILUMAB has been associated with reduced oral steroid dose, reduced exacerbations, and improvement in lung function. So comparing, sorry, my screen is having a lot of weird bars. Okay, so comparing the different biologics for asthma. So if you look at the rate of exacerbation reduction, roughly around 50% for all of them. I mean, OMALIZUMAB may be a little lower, DUPILUMAB may be a little higher, but really on average, thinking about a reduction of exacerbations of about 50% with one of these medications. As far as which had the strongest or stronger data for improvement in lung function, restylizumab, benralizumab, and DUPILUMAB had, more data on those. And I think as far as a patient that's on oral steroids, thinking about mepolizumab, benralizumab, or DUPILUMAB, as we had discussed earlier, so with omalizumab, there can be seen maybe a trend towards decreased use, but may not be able to get someone off chronic steroids altogether. With restylizumab, there might be more to come as further studies are done on it, but at this point, it's not listed as a something that can be necessarily a goal that would be achieved with that, but probably more to find out soon or at some point. So looking at the dosing of these different medications, so omalizumab, well, all of these are subcutaneous with the exception of restylizumab. So restylizumab is an IV dose, so patients need to receive this in a clinic or in an infusion center. 3 milligrams per kilogram every 4 weeks. It does have a black box warning for anaphylaxis, which was seen in 0.3% in clinical trials. The other 4 are all subcutaneous. So omalizumab is given either every 2 weeks or every 4 weeks, depending on a dosing calculation of their weight and IgE level. It does also carry a black box warning for anaphylaxis, which was seen in 0.1 to 0.2% in clinical trials. Mepolizumab, fixed dosage, 100 milligrams sub-Q every 4 weeks. It is also approved for home use. So patients can either come into clinic and receive this, or they can be trained on it to receive it at home. For EGPA, it is a different dose, 300 milligrams sub-Q every 4 weeks, and this can also cause hypersensitivity reactions. Benralizumab is 30 milligrams, again, fixed dosage sub-Q every 4 weeks for 3 doses, and then 300 milligrams every 8 weeks. So the dosing interval can be stretched out for that medication. It is also approved for home use, so patients can be self-taught on how to use this. It can cause hypersensitivity reactions. And then with DUPILUMAB, patients receive a loading dose followed by a maintenance dose every 2 weeks. There are 2 different doses that you can choose to prescribe at the beginning, with the higher dose being recommended for those on oral corticosteroids, or if the patient has a comorbid condition of severe eczema. This is also approved for home use, so patients can be taught how to use it and give it at home. And this can also cause hypersensitivity reactions. So with omalizumab, local injection site reactions can occur in about 9 to 12% versus 7 to 8 in placebo. It does have a risk of anaphylaxis in 0.1 to 0.2%, so it does carry a black box warning for this. We require patients to stay in clinic for a waiting period when they get their injections, and to carry an epinephrine auto-injector if they're receiving treatment with omalizumab, because there is that potential that they could have a delayed reaction. Use of omalizumab has not been associated with increased parasitic infection or malignancy, suggesting that IgE is important but not essential for host defense mechanisms of parasites or malignancies. With mepolizumab, there was a small number, but it was mentioned that of patients that developed herpes zoster. So generally we'll recommend that if the patient is 50 years old and up, that they receive zoster vaccination about 4 weeks before starting mepolizumab. Dupilumab, so injection site reactions can be a bit higher than with the other biologics, 15 to 18% versus 5 to 10% in placebo. Hypereosinophilia can occur, so that would be greater than 3,000 cells per microliter. It occurred in about 4.1% of patients versus 0.6% of placebo. It's thought to be transient. One of the proposed mechanisms is that while the eosinophils are blocked from activation and recruitment to the tissue, they're not blocked from progression from the bone marrow. So an absolute eosinophil count of greater than 1,500 cells per microliter at baseline was an exclusion criteria. And it's mentioned to be aware of any vasculitic appearing rash, any worsening pulmonary or cardiac symptoms, or any neuropathy that develops with peripheral eosinophilia when the patient is started on treatment, and to consider monitoring their eosinophil count within that first 5 to 6 months of treatment. So choosing a biologic, there are no true head-to-head comparisons currently between the different biologic therapies for asthma. So things that we think about, the mode and frequency of administration, a patient's underlying comorbidities, the weight, because some of these are weight-based medications, lung function, if they're on oral steroids, and then shared decision-making, I think plays a pretty big role in having a conversation with a patient about which biologic they might be a good candidate for, and what are the risks and benefits and such of that. We think about, of course, phenotyping for T2 inflammation to figure out what they would be, what a patient would be a candidate for, looking at their peripheral blood eosinophil values, generally greater than 150 cells per microliter, depending on which biologic you're looking at. One could look at their FeNO greater than 20 parts per billion, looking at the IgE level, assessing for aeroallergen sensitization as well. So as far as comorbid conditions, so for example, if someone has severe asthma and they also happen to have severe urticaria, one might think about omalizumab because it is FDA approved for those two conditions. If someone has severe asthma and also has very bad atopic dermatitis or also has very significant nasal polyps, then dupilumab may be one that you consider for that patient. Changing from one biologic to another certainly comes up. There are a couple small studies that I mentioned here. So with the Asthma trial, this was the efficacy and safety of mepolizumab in uncontrolled patients with severe eosinophilic asthma following a switch from omalizumab. It was a small uncontrolled study, but they found a 64% reduction in exacerbations and 120 milliliter improvement in FEV1 when patients who were not controlled with omalizumab were changed to mepolizumab. A different small study found improved asthma control and elimination of sputum eosinophilia when oral steroid-dependent patients on mepolizumab who continued to have eosinophilia associated with asthma exacerbations were changed over to weight-based IV rosalizumab. I hope and think that in the future there will be more guidance as far as choice of biologics. There's something called the Precise Clinical Research Program. It's sponsored by the NHLBI, and they're enrolling patients profiled with biomarkers and using this trial design to provide precision medicine approaches for the management of patients with severe asthma. So hopefully there'll be more fine-tuning as far as helping to determine what medication a patient might get the most benefit from. As far as the follow-up on a patient on a biologic, there's really little guidance regarding time to follow-up after initiating therapy, as far as frequency of office visits, type of monitoring, deciding on treatment failure. It may take several months to assess efficacy if you're measuring frequency of exacerbations, whereas other measures of improvement may be seen within weeks. With dupilumab, the FEV1 can increase within as early as 2 to 3 weeks. In the GINA guidelines, so the Global Initiative for Asthma guidelines, they suggest an initial evaluation in 4 months after the patient's been started on the biologic to assess efficacy. If they have a good response, then follow up every 3 to 6 months. If there's no response, then consider an alternative biologic. And if it's really unclear, then considering extending the trial to another 6 to 12 months. There's really no consensus on monitoring absolute eosinophil count or FeNO during therapy with biologic, with the exception of checking for their eosinophil count on dupilumab if a patient's developing new symptoms that could possibly be associated with eosinophilia. Another question is, once control is achieved, how do you step down other therapies? And generally, the consensus would be that most people would start with reducing their oral steroid dose before making any adjustments to any of their inhalers. How long to continue a biologic? Well, they're not immunomodulating, so they work while the patient is on it. If you stop the medication, it can result in a loss of asthma control. So using a biologic, the approach is not curative. It treats the condition, but after discontinuing the drug, then the disease can reoccur. So just thinking about the future needs for optimization of biologics. So having inexpensive and easily obtainable point of care biomarkers for type 2 low asthma, safe and effective biologics for type 2 low asthma, that precision medicine we were talking about where phenotype, endotype, biomarker driven biologic specific therapies precise to a patient. Possibly a biologic that can induce true immodulation, so can actually prevent or alter the disease course. Obviously want something with a favorable risk-benefit ratio, convenient dosing, affordability is certainly important, and maybe even biologics that can prevent recurrent emergency department visits or other markers of loss of asthma control. So in closing, just some key messages. So what we talked about today are the 5 biologics approved for the type 2 severe asthma. Peripheral blood eosinophils, thinking about at least greater than 150 cells per microliter, and or an FeNO of greater than or equivalent to 20 parts per billion are biomarkers of T2 inflammation. We talked about omalizumab targeting IgE, mepolizumab, rosalizumab, and benralizumab targeting IL-5 processes, and dupilumab targeting IL-4 and 13. primary outcome improved by TT biologics is the prevention of asthma exacerbations, and it's thought that MEPOLIZUMAB, benralizumab, and DUPILUMAB have steroid-sparing effects. So thank you for your attention, and I'd be happy to answer any questions. Okay, well, thanks everyone.